Hello everyone. Now we're down to the last classification of disease for the gastrointestinal system, the neoplastic disease. First, we have the tumors of the esophagus. Although benign and malignant tumors could occur anywhere in the esophagus, tumors of the lower third are the most common. Benign tumors are almost always leiomyomas, which are smooth muscle tumors. These benign lesions present as intramural defects in the barium outlined esophageal wall. The exact location of a leiomyoma, which appears as a homogeneous soft tissue mass, may be determined by CT scan. Treatment for leiomyoma consists of surgical removal through a thoracic or abdominal incision that avoids esophageal resection. There are two types of esophageal cancers and both have different clinical and radiographic features. These are the squamous cell carcinomas, which most commonly arise in the body of the esophagus, and the adenocarcinomas that were typically at the gastroesophageal junction. The diagnosis is made by endoscopic biopsy of the lesion. For the staging of cancer, CT scan is used, regardless of the type of esophageal cancer. Chronic irritation of the esophagus is thought to be a predisposing factor to squamous cell carcinomas, with such irritation caused by particular agents including reflux, alcohol, and smoking, and disorders such as achalasia and esophageal diverticula. So the primary symptom of esophageal cancer is dysphagia or the difficulty of swallowing. Surgery is used as a treatment with the goal to excise the tumor and regional metastases. Chemotherapy, radiation therapy, or both may be used as an adjunct to surgical intervention. The radiographic appearance of a malignant squamous cell tumor may include mucosal destruction, ulceration, narrowing, and a sharp demarcation between normal tissue and malignant tumor. As mentioned earlier, adenocarcinomas usually occur in the lower esophagus around the gastroesophageal junction. Many believe that these begin as primary gastric carcinomas that invade the lower esophagus, while others believe that a direct link exists between a disorder termed Barrett esophagus and the development of adenocarcinoma of the esophagus. Similar to squamous carcinomas, adenocarcinomas spread via the lymph nodes, and unlike the squamous carcinoma, these also spread below the diaphragm, so metastases to mediastinal structures and hematogenous spread to liver, lung, and bone occurs readily. Early adenocarcinoma appear as plate-like lesions or sessile polyps on the radiograph, and advanced tumors appear as infiltrating lesion with irregular narrowing of the lumen with abrupt asymmetric borders. Next is the tumors of the stomach. Most stomach tumors are malignant, and the outstanding preponderance of these are adenocarcinomas. The incidence of gastric cancer varies strikingly by geographic area, race, diet, heredity, and sex. Most gastric carcinomas develop in the pyloric and antrum regions, particularly along the lesser curvature. The most appropriate primary diagnostic procedure is an upper GI endoscopy with biopsy. Endoscopy is often followed by a fluoroscopic upper GI series. Symptoms of gastric tumors are often vague but include bleeding, vomiting, loss of appetite, weight loss, and early satiety. Tumors are radiographically indicated by a relative rigidity of peristalsis and filling defects on compression. Filling defects manifest as areas of total or relative radiolucency within the barium column. By identifying lymphatic involvement and extragastric spread of cancer, CT scan is also useful in the staging of cancers. Surgical removal of gastric cancer has been the only successful treatment. A subtotal gastrectomy is the usual procedure. Third, for our GI neoplastic diseases is the small bowel neoplasms. Most small bowel cancers occur in the duodenum and proximal jejunum. One predisposing factor for small bowel neoplasms seems to be the degree of polyposis in other areas of the GI tract. a condition frequently determined by heredity. Another predisposing factor is Kaposi sarcoma, most common in patients with AIDS. Intermittent abdominal pain, sometimes described as cramps, is the most common symptom. Endoscopy with biopsy is the most common means of identifying small bowel neoplasm, but small bowel barium studies may assist in the diagnosis. Surgical resection is a primary means of treating small bowel neoplasms, both benign and malignant. Another neoplastic disease is a colonic polyps. These are small masses of tissue arising from the bowel wall to project inward into the lumen. Polyps are more frequently noted in the left colon and particularly in the rectosigmoid areas. Although most polyps are asymptomatic, all should be removed, especially adenomatous polyps, which pose a greater risk of malignancy. Those over 2 centimeters in size have a malignancy rate of over 50%. However, most never reach this size. Patients with polyps may have rectal bleeding, constipation, diarrhea, or flatulence, but most are asymptomatic. Radiographically, an ear contrast barium enema is the examination of choice, with the polyps manifesting as rounded filling defects or contour defects in the barium shadow. Last is the colon cancer. Colorectal cancers are the third most common tumors in the United States and the most common gastrointestinal cancer. Additionally, carcinoma of the colon is the third most common cause of mortality from cancer. Predisposing factors include a family history of familial polyposis and ulcerative colitis. Environmental factors also seem to correlate with colorectal cancer, as countries with higher intakes of sugar and animal fats have higher incidence than compared with countries with a higher fiber intake. Adenocarcinoma is the most common type of colorectal cancer and is derived from the glandular epithelium of the colon. It begins as a benign adenoma that undergoes a slow malignant transformation. Detection of colorectal cancer, when localized, is associated with a 5-year survival rate of approximately 80%. The evaluation of colon cancer includes fecal blood testing, proctosigmoidoscopy, colonoscopy, barium enema, CT scan, transrectal ultrasonography, and PET imaging. Double contrast barium enema has been noted to produce more accurate diagnosis compared with a limited single contrast study because of the enhanced display of subtle mucosal abnormalities otherwise masked by a dense barium column. The radiographic appearance of adenocarcinoma has led to its designation as the napkin ring carcinoma or the apple core lesion, as the edges of the lesion tend to overhang and form acute angles with the bowel wall. The primary means of treatment are surgical excision of the primary tumor and its margins and the resection of the bowel, if possible. A colostomy may be required depending on the size of the tumor. Radiation therapy or chemotherapy is generally given before and after surgery for rectal cancers, especially in those with lymph nodes positive for metastases. For inoperable tumors, radiation therapy is given to reduce the tumor size and its resultant complication and also to provide pain relief. Chemotherapy is given when the cancer has metastasized.